Okay, we've heard reference a few times throughout the last couple of days to a type of treatment that many of you may not be familiar with called EMDR. I was not too aware of this until recently when I got to meet Gary Brothers, who I'll be introducing here, and Rick Levinson and Bruno Lepore, who are all practitioners here in the Austin area, and all have had an opportunity to go around and train other psychotherapists in this modality. This whole concept of eye movement desensitization and reprocessing is fascinating, and it's emerging as a frontline treatment for post-traumatic stress disorder, pain and substance use, and other types of chronic behavioral health conditions. Gary is a practicing psychotherapist in the Austin area, and as I said, he has trained many of the people around Texas in EMDR techniques, and he's going to tell us more about EMDR. And with that, one other thing I wanted to mention is that the state had provided us, everyone here, with an opportunity to take this home with you, which is the CDC guidelines for opioid prescribing. If you haven't had a chance to get this, can you raise your hands and we'll come around and distribute it to you?
Thank you, sir. Well, it's kind of hard to be at the end of the day of a two-day workshop. It's kind of dwindled down a little bit. People are probably tired. Anybody need to stand up, shake their brains awake or anything like that? I promised some people we'd start with some table dancing. Anybody up for that? No? Okay. So, well, I've been in my field about 26 years. The first 16 years, I really focused working with at-risk youth, primarily teenagers, starting off in the Chicagoland area, and then spent about 10 years of that, 16 years in Hawaii, working with underprivileged and kids there that were in impoverished areas and really struggling with socioeconomic issues, drugs, violence, and so forth. And if people ask me what kind of therapist you are, I'd say I'm a trauma therapist. And then when I moved to Austin, I think it's 12 years now, or maybe 11 years now, I kind of fell into the chronic pain field. I was offered a position working with a chronic pain company, and I didn't really know anything about it. But they offered to give me the training on that. They said I had good clinical background and I would fit right in. And I found that I did, because what I realized these were just adult patients of the ones I had been working with when they were kids. And I got to see everything that happened with the kids if they never got the treatment they needed, and how their bodies then developed all these illnesses and breakdown through constant, when your body's in this constant state of hyperactivation, it does break down. And when you're in these difficult life situations and you live a rough life, your body gets worked over and you develop the issues that I was seeing in day-to-day with the people that I was working with. So I'm not going to go over a lot of details because I've got a short time to cover a bunch of information, but what we've just heard, and I do have some statistics here, I'm not going to go through much of them, but I do want to point out a couple different things, and that is down towards the middle of that is the references between post-traumatic stress disorder and chronic pain. There was a recent study last year through the VA. They did a study with looking at people with post-traumatic stress disorder and chronic pain. And overall, they said anywhere between 40 to 75% of people with post-traumatic stress disorder also have chronic pain issues. But when they broke that down, they looked at the people coming in for chronic pain treatment, and approximately 40% had some significant post-traumatic stress symptoms. They may have not met the full diagnostic criteria to say post-traumatic stress disorder, and we'll talk a little bit about what that means. But when they looked at those coming in for post-traumatic stress disorder treatment, approximately 75% reported issues with chronic pain. And so we can really see that there is that interrelatedness between trauma and pain. As other people have said earlier today, I don't really need to emphasize that anymore, but we'll see the neurobiology and the neurophysiology today on why that is the case. And as I tell people, I'm kind of a brain and a nervous system geek. Anybody else here that way? Not really. Well, you're in for a treat, that one person in the back corner, or everybody else. I will probably put you to sleep, but hey, I apologize in advance. So pain can be complicated, and now we're going to talk a little bit about some of the complications of pain. I picked a couple of comics here, but there's some truth to that, and we'll talk a little bit why. And pain solutions can be complicated too, and actually there's some truth to this unique solution, this German solution. But when I start, I want to get to this point. When I get referred to people, I get a lot of referrals from healthcare providers, especially neurologists, for cases that may have not responded well to the traditional approaches, or they may be a little atypical or have trauma in their background, therefore they're not responding, so they'll refer to me. And I'm certainly not going to give a lecture on anatomy to a room that's at least half filled with physicians, as being a psychotherapist here, but I do want to talk a little bit about that nociceptive pain and the neuropathic pain. So a good example of this, if I'm rubbing my arm here, my sensory nerves and my peripheral nervous system, they're just feeling sensation. There's no pain going on unless I have allodynia, which I don't, which would just mean that that would be interpreted as pain. But right now, these sensory nerves are just doing their thing as they're supposed to. Now, if I pinch myself, now I've created nociceptive pain. The same sensory neurons now are becoming nociceptors. And how that happens is these same sensory neurons now release a substance called substance P that turns on the pain network. And that pain network then sends the pain signal to my brain. And then it's a relay, but it's an electrochemical relay system that now up in my brain, up in the limbic regions of my brain, that's also going to release substance P, which is it's a polypeptide, which is we believe, we're doing a lot of research right now on that, but we believe it to be the main pain neurotransmitter. But then in the deeper limbic areas of my brain, that releases substance P, and therefore I experience pain. But without my brain, I don't experience pain. And it's this pain process through activating the nociceptors through the release of substance P that now I experience pain. And even with neuropathic pain, which is often where there's injured nerve or irritated neurons, it's still a relay process. Even if I have sensitization to the systems, the central nervous system, or the sensitization in a nerve relay system, it is still a pathway system, a relay system, and without the brain, we don't have pain. And so when clients come to me and say, hey, I think my doctor thinks my pain is in my head, I say, well, they're kind of right, but pain is real. We don't make up pain unless we're malingering, and they usually don't get to me because I don't prescribe medicine. So, so we want to look at the brain to start. There's 16 places in the brain that process pain, and without the brain processing, we will not experience pain. And we want to look at what happens with the difference between acute and chronic pain. But with these 16 areas, the 7 in the lower areas, 7 in the brainstem and the cerebellum, those aren't conscious. It's only in the 9 conscious area of the brain that we're actually going to experience pain, and I'm going to flip to that over there. These are the 9 areas in the conscious brain that when they're activated, we're going to experience pain. And all the relay systems from the peripheral nervous system up through the spinal cord, up into the, through the brainstem, into the conscious area of the brain, it's not pain truly until we process it as pain. And each of these substructures do many other things beyond just processing pain. In fact, it's only about 5% of the neurons are dedicated to processing pain. The other 95% are doing the other things that these substructures are supposed to be doing. And they work together with other substructures depending on what's happening in the body. But when we're constantly inundated with this pain message coming up through our body, we have these changes that occur in the brain, and that 5% can go up to anywhere between 15 to 20 So we get a 5-time increase that the brain can adapt. It learns pain, and it does that by creating these the neurons through dendritic connections. The synapses wire with each other, and we create these pain networks, and the brain actually learns and gets better and better at processing pain. And that's through the neuroplasticity. What fires together wires together, and over time, that chronic pain, through the pain generators, it goes up through the pain pathways, the pain becomes strengthened and hardwired more and more. And we can see that if we look at diagrams of the pain, of the brain with the difference between no chronic pain and chronic pain, we can see that the brain loses ability to downregulate, to calm and soothe itself, while the part that is becoming more and more excited destabilizes the brain, and then the other parts of the substructures that are meant to do other things become less and less able as the neurons are being recruited for more and more pain processing. And this is a process, again, that occurs over time. It doesn't occur just, that's why, over years, over months, over years, and over time, this becomes worse and worse. And this is just like any process that we do. If we play the piano, the more we practice it, the better we get. We're creating connections through our body, and into our brain. We get better at it. And the good news is we can undo that, and that when we work with certain techniques like EMDR, we're going to talk about how we do that as part of our protocol. But I'm going to switch over to talk a little bit about trauma, because we see with trauma, the same things are happening with post-traumatic stress. With the same activation that occurs over and over, the brain itself structurally changes. It's not a psychological condition, it's a physiological condition, and the brain itself changes with trauma. So let's talk about trauma for a second. So normally when we think of post-traumatic stress disorder, we think of one type of trauma, but there's really 2 different types. But the one we normally think about are these severe life-shaking events. We think about people who are service members overseas in combat. They experience these horrific events where they experience their comrades, their buddies in horrific events, and it really upsets and disturbs their nervous system, and they develop these traumatic reactions. Or other times it might be near-death life experiences, a bad car accident, or where we perceived ourselves being our lives being in danger or seriously harmed, physical, sexual assaults. And by definition, that's what we say, to meet the criteria of post-traumatic stress disorder, you need these very powerful shock events to meet the diagnostic criteria. But that's only one, if we're looking at it from a neuroscientific point of view, that's only one type of trauma. The second type of trauma is, smaller painful life experiences, but are repetitious. And that might be witnessing your parents having domestic violence growing up, or emotional abuse, or being bullied growing up, being in an impoverished area where there's feeling of powerless and hopelessness, being in work environments where you feel powerless, hopeless, and so forth, or you don't have any perceived agency over your life. Or even vicarious trauma, where you're witnessing other people's trauma and pain. Those, actually, research shows, can have even more damage to, if we talk about, functional brain imaging, those have more damage to the nervous system and the brain substructures than 1 or 2 shock events. And so if we want to define trauma from a neuroscientific point of view, it's any experience that creates a stress response strong enough to have a lasting effect. Or, as I tell my clients, it's the past living in the present in a body state. And we're going to talk a little bit about how that happens. So if we look at the brain, we're constantly, every day, all day long, being bombarded with information through our senses, sight, smell, taste, sound. And our brain is organizing all this information. Of course, we can't remember everything that we are exposed to. And not only is our brain taking it in from the outside, but it's responding to it internally. In fact, our brain reacts, it reads what's going on in our body and reacts to it about 30 times a second. And if you do the math, that's about 1,800 times a minute, 108,000 times an hour, and about 2,592,000 times every day day in, day out, every day of your life. So your brain is constantly sorting through what's going on around you and what's going on inside of you and recalibrating itself. Now, how it does that, though, it has these two separate tracks when we talk about memory and how it's responding to all this information and what it's going to keep and what it's going to discard. And it's very effective at getting rid of things. It's going to learn to hold on to things that resonate on the body system, what we call the implicit system. Now, the explicit system is really what we talk about memory, and that's our thinking memory. And that is really involving our hippocampi. We have a hippocampus on the left hemisphere and the right hemisphere. And it's a little more complicated than this, but by and large, our hippocampi works with our prefrontal cortex, and that is organizing all the thinking information, all the cognitive aspects of our experience. That's the autobiographical information, the facts, the general knowledge that puts ourselves in place and time and space and time in that situation. Now, the implicit information works through the amygdala and then down through the hypothalamus, the thalamus, down through the brainstem, and then down through the spinal cord and all those sympathetic nerves that then work with the muscle systems, and then through the ganglions and plexuses that then connect to the different organs, and how we have that threat response, because that's what will activate that. If there's a danger or a threat or a stress, adrenal glands will then activate and we'll have this multisystemic wide threat response. Not only will we react in a sympathetic stress way, but we're also holding information. That's a memory system as well, and we store information. For instance, if you think about something in the past that was really upsetting to you, and you feel that tightness in your chest, or you feel that lump in your throat, or you feel the discomfort in your gut, that's your implicit system remembering, recalling that experience. And in fact, if it's been quite a while, that is trauma on a neuroscience point of view. And it's also not well for your system to be holding that information for very long. And we're not really supposed to keep it that way. And what's supposed to happen is over time, in fact, during our REM sleep, as we sleep, our brain is supposed to work this information out. We're supposed to integrate it and consolidate it. It's called cortical consolidation, and it's during our REM sleep, why we have REM sleep, that our left and right hemispheres, our hippocampi and our amygdala and our prefrontal cortex, are working this information out through stages, and we're working it out of our implicit system and attaching what we experience to other adaptive life lessons, and then saying, oh, okay, we're learning from this. We're attaching it to other lessons, integrating it with them, so that we can release it from our alarm system, which is the implicit system, and then just remember it on a cognitive level and make sense of it and move forward with life. Now, that's what's supposed to happen. Sometimes things break down, and that's not about character. It's not about psychological weakness. In fact, I tell my clients, nothing is purely psychological. Everything is psychophysiological. Every thought, every emotion has a physiological counterpoint. And so how things break down is when we get this huge activation with stress chemicals and electrical charge in my brain. When I experience a very upsetting event, what can happen is the hippocampus, it's very sensitive to stress chemicals and that electrical charge, and that can go offline and stop processing that information. So the implicit information then gets stored alone, but not integrated or connected to the explicit. In fact, when people don't remember, when we say they repress that information, that is really the hippocampus having gone offline completely and losing complete time and date of that situation. We lost the cognitive aspect of the memory, but the implicit has still been recorded and it will still be felt. But they're completely separated. Now, what will happen is afterwards, we're still going to try to have this cortical consolidation, and that's why one will experience nightmares and so forth, but the same thing will happen is there'll be too much stress chemical, too much electrical chemical activation in the brain, and the hippocampus goes offline, and that information, again, stays unprocessed. And over time, it doesn't connect, and that implicit information that is not connected to autobiographical, it's raw sensory data. We just feel it as fear, we feel it as tightness in our chest, or our shoulders tensing, or a reflex to jump backwards, and it just stays there indefinitely until somehow it does get processed. And time will not heal that unless some sort of intervention or some sort of way that sometimes it will happen on its own, but often it doesn't. And if we've had multiple situations where this has occurred, our brain actually gets less able to process information. I'm going to talk in a moment, slide, why that happens. But the important thing to know at this point is that it's not getting connected to adaptive lessons that we've learned earlier in life, because it's not connecting to the explicit information and then linking to that adaptively stored information from previous life lessons. And it's not going to be changed by, further life lessons, because it's staying stuck. Now, time won't heal that, and what will happen is when something triggers the implicit, it can stay completely disconnected from that explicit. I might feel this implicit emotion react and have no idea that it's tied to that time and place when it first happened. And so I'm going to feel as though it's about now. I'm going to experience as though it's about you, and you're making me feel this way, and I'm going to react, not only that it's about you, but I'm going to react in the way that I would have reacted then. So I might have this huge disproportionate reaction, and you'll have no idea why I'm reacting that way. And so there is some learned where we say, and I don't disagree with what we've heard earlier about how I'm used to chaos if I grew up in that, but really the idea is that I'm re-experiencing the chaos rather than I'm used to it. I'm just reliving the chaos, and I won't know why. Now, on a brain level, what happens is that the amygdala, because of this constant hyperactivation that happens, again, we look at what happens with neuroplasticity, the amygdala gets better and better at becoming activated. We're going to have persistent dendritic growth, dendritic spinal formation, so it gets better at becoming hyper-responsive, while the hippocampi and the medial prefrontal cortex, they both atrophy, and they get less able to do what they're supposed to do. So over time, more and more trauma is likely to collect. And so we'll get these maladaptive memory networks where we'll get trauma connected on trauma connected on trauma, and we'll have more and more activation that are in similar ways, but also not connected to those adaptive previously learned lessons. And that's what needs to be done with the clinician is, the well-informed clinician, is to let's fix this. And the good news is we can fix it, because trauma is one of the most treatable conditions. But traditional talk therapy usually is not effective. You need specialized treatment. And right now, we have really evidence-based. There's two forms. One is EMDR, the eye movement desensitization reprocessing, and the other is CBT, the cognitive behavioral therapy, and most specifically, a form of that called cognitive processing therapy, and that's trauma-focused and usually involves a prolonged exposure experience while they're processing that. Well, I'm going to focus on the EMDR side and not talk too much about the CBT side just because of time. But EMDR is one of the most researched treatment methods out there. In fact, the National Institute on Mental Health published a study that showed there's about 75 resolution of adult onset PTSD in about 6 sessions. Now that sounds great, doesn't it? The reality, though, I got to say, with chronic pain is a lot of our clients didn't develop the post-traumatic stress disorder in adulthood. They wouldn't be developing chronic pain if that was the case, so it might be a little more complicated. It is evidence-based also for anxiety and depression, and there are wonderful protocols for addiction and substance use disorders, for triggers, and as well as for chronic pain. And the good news also is clients don't need to have they don't have to be psychologically minded to participate in this, and they don't have to have a lot of insight. because how we do this is we do some preparatory work. It doesn't have to be a lot of preparatory work in most cases, but what we want to do is we want to recreate, and we're really allowing the nervous system to heal in its natural way. Just like if I broke my arm, I went to the ER, they set the bones, we cast the bones heal naturally. What we're doing with EMDR is we're creating a safe, structured environment. We're going to now link that implicit information, the body sensations, what the body feels like, how it feels like reacting. We're going to link the emotions with the disturbing memory, the thoughts related to it, the belief, the images that come up. And we're going to then combine it with some eye movements or some other form of bilateral stimulation in a way that doesn't get them too overwhelmed, so that then they can process through the information in manageable ways. And through that, what we find is that unprocessed information gets processed along the appropriate neurological pathways in an accelerated rate. And through doing that, it is very efficient, and it links the data to the data from that experience to previous memories that have been adaptively stored in their permanent memory network, and we can eliminate the disturbance. And that's the thing, is you keep doing it until that disturbing memory is completely eliminated, and that there's a positive shift in self-perception, and then you reinforce that. And through that, there's no more propensity to have that negative behavioral reaction or being triggered, and then the body can return to that state of psychophysiological coherence or calm. And in essence, we're giving the brain another opportunity to do what it wasn't able to do at the time of the experience or afterwards as it was trying to heal. So in a nutshell, that's what EMDR for trauma is doing. But I want to talk a little bit about what we do for chronic pain, But before I do that, it is endorsed by wonderful organizations. You'll have the slides. I don't want to spend too much time. So let me talk a little bit about what we do for chronic pain. And EMDR isn't, you have to learn and understand how it works for chronic pain. So you just can't say, well, I know EMDR, I'm just going to do it with chronic pain. You have to learn the protocols as well. And I want to say, if you're going to be effective at treating chronic pain, EMDR is one piece of the intervention quiver. You have to do other things as well, but approaches need to be fluid, deliberate, and strategic, and they have to incorporate the understanding of the mechanisms of dysfunction and incorporate all the needed mechanisms of intervention to impact recovery and healing. So, I like what we've heard so far that, and I was going to say that here, but other people beat me to it, but chronic pain is a syndrome, and we really need to understand that it is a syndrome, and with that, there's systems of dysfunction that have, co-occurring and co-reinforcing, aspects to that. And one of that is those unfortunate neuroplastic changes in the brain that are occurring in those substructures. Like I said, that, in acute pain, only 5% of the neurons are dedicated to processing pain, and that can go up to 20%. And so we need strategies that are deliberately focusing on how those substructures are working and how they're dysfunctionally working in a chronic pain state, and using those substructures to bring them back into a more acute function state. And there are specific strategies and ways to do that that are strategic, organized, and that also people can practice on their own in between sessions. Another big piece of this is the chronic multisystemic threat response activation that's occurring in the sympathetic nervous system. And we know that threat response activation is at the core or a major player in many chronic health conditions, autoimmune disorders, and even why so many people develop chronic pain as compared to people who don't. And so we have to, address the habituated nervous system and that psychophysiological incoherence and calm that down during sessions and in between sessions, because if not, it's only going to perpetuate the pain amplification and the systemic breakdown in the body. So that's a huge piece, and that's where I think, other, modalities like the yoga we were talking talking about become a huge piece of what we can do, partnering with other, providers, and how to bring that body back into a state of balance in what's called the default mode network. We're actually supposed to be in a state of calm most of the time, but our clients are in a state of activation most of the time. And when that happens, we have this neurotransmitter and biochemical breakdown and imbalance that, unfortunately, as we try to treat the pain, sometimes the medicines we treat them with only further causes problems with that. So we want strategies and interventions that are also geared not just to calming the body, but that we can do things that are really targeting and honing in on increasing GABA. And bilateral stimulation can help with that. And we also have to address the pain gate facilitation, both on a thinking, behavioral, emotional level, to get those pain gates closed or inhibited again, so that there is a less pain perception, as well as addressing the long-term potentiation that is occurring. I'm going to talk for a second about that, and as a result of that, too, that unmediated inflammation issues. Am I doing okay on time so far? 4 minutes. I'm going to use every 4 of those minutes, too. Okay, so with EMDR, we want to look at, I kind of covered that, so I'm going to talk about EMDR specific. So EMDR, generally speaking, it works well for pain, and I want to talk again about what we know, or what we're learning, I'll say, what we know now and what we're learning about substance P. How many people are familiar with substance P? Okay, great. More and more of the research is showing that people with developmental trauma have excessive amounts of substance P in their body, and that makes them prime to develop chronic pain. People with highly anxious and depressive states have excessive amounts of substance P. People who are in hyperarousal, their body is releasing about 5 times the amount of substance P and activating 3 to 5 times the number of cells that receive that. And chronic pain itself releases up to 5 times the amount of substance P. So that's what activates the nociceptive pain, but also what that does is that activates in the brain, if we have too much substance P, that tells astrocytes in the brain to release pro-inflammatory cytokines, and so then the cytokines cause inflammation, and the inflammation then tells the limbic system to release more substance P, and so we get this cycle of substance P and inflammation going on. In the peripheral nervous system, the fibroblasts that normally release collagen, but when the substance P gets activated, then we go into an inflammation response, and then the fibroblasts release pro-inflammatory cytokines in the body. So we get this really unhealthy cycle of pain activation, inflammation, and eventually systemic breakdown as a result. So if we can do interventions with and get to the root cause of that, resolve the trauma, resolve the depression, and resolve the anxiety, and I truly mean resolve, because that's what we're trying to get to with EMDR, then we can really stop this process and abate it. Now with pain, there are wonderful protocols, and I use them a lot, where long-term potentiation is where there's an original injury or original excitation of nerves that then turn on a whole nerves in this relay system, and those nerves stay excited, but then when the original injury heals, the rest of the nerves don't turn off. So for instance, short-term potentiation is I'm pinching myself and it's sending a relay system. Now when I let go, the nerves turn off, but long-term potentiation would be when I let go, the nerves stay turned on in my arm all the way up, and I feel it in my brain, of course, because that's where I process pain, and that can last for hours, days, years, indefinitely. Now with EMDR, what we can do is we can create a long-term depression process where we target the pain on a cellular level, the brain and where the brain processes it and the higher order areas of the brain, and then link that to a more slower bilateral stimulation process, a rhythm that inhibits it on a cellular level, and as well as downregulates the brain on the higher order areas, and then we can get to this, and then get to release and inhibit the nerves from being turned on. And it's, people don't believe it, but when they come into the office, but oftentimes we can bring that pain from an 8 down to a 2. Oftentimes we can abate it completely, and they have great, and then we do some installation where actually we do a long-term depression to turn it off, and then we do a long-term potentiation to reinforce it staying off, so we're not turning it back on in that. But we can abate the pain states using the body, how it works. But you have to have that targeted strategic know-how to do that. Sometimes it'll take a session or 2, sometimes it'll take multiple sessions. It's hard to say how long it'll last. Everybody's unique and individual, but it's really a very powerful and effective intervention. Now, we have to do all of these things in conjunction, and and that's where we talk about behavioral health. Therapists, if they're going to be an effective pain psychotherapist, I tend to be egocentric and just say therapist, forgetting that there's so many other types of therapists out there, but as an effective pain psychotherapist, we need to know this information, and not just know this, but be able to teach it to our clients, because that's going to empower them to buy in, because this stuff takes work, this takes practice, this takes, time. It's not a quick fix, it's not a pill. It's something that they're going to have to participate in. And I, of course, part of what I do is also teach people to get involved and to move into yoga and to physical therapy and to exercise. That's a big piece of all this that I'm not able to cover here, but we have to get them to create. But even them just knowing that and buying into it shifts their neural template and how they work and how their brain is going to work. So I'm going to end now because I'm out of time. I don't even think, do I have any time for any questions? Or
Why don't we have any of you that want to talk to Gary, you can gather over to the side or something and chat, and we'll go from there.
all right, perfect. Thank you.
Thank you, Gary.